Hi, everybody. This is our first webinar of 2025, and been looking forward to it for a while. My name is Alan Higgins. I'm Health Equity Network's lead. I'll invite Jamaica to introduce herself.
Hi everyone, I'm Jamaica. It's great to see so many people on the call today, and I'm the Health Equity Network coordinator.
And just to note, Jamaica's having a problem with her microphone, so it's on her end. And welcome to the Health Equity Network webinar. We run one of these webinars each month, usually on the last Thursday of the month. Today's webinar is on building health equity, the role of the property sector in improving health equity, which is a report from IHE which came out a few weeks ago. And we have three great speakers lined up. We have Clare Delmar, who's a housing consultant and campaigner, who will begin the presentation in a moment. We have Mickey Alexander, who's a senior research fellow at the Institute of Health Equity. And we have Jordan Whitewood Neal, who's a researcher at Quality of Life Foundation, also involved in putting the report together. And we'll have input over about 20 minutes or so. And after that, we'll invite people to ask questions, make comments. The usual rules apply. If you could keep your microphone off while the presentations are going on, then please do so. And when it comes to the questions, if you could use the hand up facility, then that will just keep us in order of who to come to first. As well as logging your details in the chat, you can also put questions in there and comments. And what we'll do is try to come back to those when we come to the questions and comments section. You can also just put comments in there that might be responding to other people's comments. So please do use that facility as well. Finally, the webinar is being recorded. And what we tend to do is then edit it slightly and then put it up on the Health Equity Network platform in a couple of days' time. So if we're all good to go, then I will pass over to Clare Delmar to start us off. Clare.
All right, thank you so much. I'm so glad we're able to talk about this today. This last day of January? No, second to last day of January. Yeah, as Alan said, first of all, we do not have slides, so I hope that's okay with everybody. We decided we want to talk with you and not and talk about the report, but also talk about the context, which is what I'm going to be focusing on for a few minutes. So I'm going to tell you a little bit about how this report came to be, because it didn't just come out of a vacuum or out of thin air, and the context is actually quite important for why it happened in the first place and how we chose to undertake it and how we think we might take it forward in the future. So I'll talk a little bit about that. And then Mickey's going to tell you about the structure of the report, what we actually did, the evidence that has been built from this investigation. And then Jordan is going to talk about some of the insights that he gained from engaging with various stakeholders in the development process, which included both the development or property industry, but others as well. And he'll talk a bit about that. And then we're all going to explore what some of the recommendations are that we came up with through this process. And that should all take, as Alan said, 15, hopefully no more than 20 minutes. And then we will look forward to hearing from you what you think and what you think about the research and what you think about the recommendations that we've put forward from that. So yeah, the background to this. Where are we now? I think I just said January 2025. So this sort of genesis, if I can describe it that way, is actually, it's about 2.5 years, maybe a little bit longer, which probably doesn't sound like a long time. But the reason I want to explore a little bit about this with you is because these things do take a long time. And I think I want this context to be really palpable as we discuss even the recommendations. See, we're talking with people and organizations that we cannot persuade overnight to undertake change of practice and change of behavior. And so in some ways, saying this is 2.5 years, you know, some people say, wow, that's amazing. Like, it's only 2.5 years. I mean, for me, it's felt like an eternity. And, you know, we're actually at this sort of inflection point now, which I'll come on to. But basically, the genesis really was sort of mid 2022. And I wrote a blog, which I'm happy to share with everybody later. I probably should have done it before, where I asked the question about why doesn't the development industry organize and work collectively. Because I'd come from a lot of other industries. I worked in financial services many years ago. I work in healthcare now. And I find there's a lot of collaboration, a lot of cooperation, a lot of shared missions. And the property industry, which I also know because I'm an urban planner and I worked a lot in building PFI hospitals, actually doesn't really like to organize. In fact, when I was doing those proposals and ultimately the developing the contracts for PFI hospitals, as much as we may all mock the PFI process and have a negative view of the outcome, the reality was it was the first time in my experience that industry leaders cooperated to actually produce something. So that has something to say in itself. But the industry just doesn't seem to want to work in a cooperative way. So I did this blog where I said, why doesn't the development industry work together? Well, one of the first things, and this came out in our report, is we actually struggled to even find a language. Like, what is the development industry? And in the end, the report, as Alan said, is called Building Health Equity, the Role of the Property Sector. And that there's a reason why we called it that. We can discuss that later. But I actually felt we were regressing and using that word property because we don't really have a definition. Sometimes we say the built environment, which sounds a bit clunky. Although a lot of people identify with the built environment. But I think even the fact that we were struggling and people pushed back on me from my blog saying, well, what is the development industry? But anyway, what I was asking in a slightly provocative way is, why doesn't the industry work together to find solutions to some of the problems that they often on an individual organizational basis constantly berate? So for example, why does planning take so long? Why do we have so many NIMBYs? Why do we have so many objections? This is costly. Why do we have to delay, and then ultimately a project becomes unviable? So these are questions that I said, I think a lot of these could be addressed collectively. Why don't we do that? And that was like in mid-2022. And by the early autumn of 2022, I got the attention of a guy who was and is still the CEO of the Barclay Group. I'm sure all of you know Barclay Group, and there are many subsidiary organizations, one of the biggest house builders in this country. And I got his attention and I said, okay, let's put together a roundtable of leaders in this sector. And so we started to do that. And that only took a couple months to organize. And I had as a speaker, Sir Michael Marmot, who I think all of you know. And he came and he talked about health equity, which, again, back to the issue of language and semantics, the people sitting around that table had no clue what this even meant. Because they come out of a built environment. Most of them were investors and in various ways, some more passive investors, some actual house builders. Obviously, Barclay Group falls into that category. And they had no idea. And Michael, as many of you know, is a very passionate, very compelling, very persuasive individual. And he really got people listening around the fact that, it sounds almost like back to basics, but he actually said, you have an impact on health. And because he's an epidemiologist and he's very evidence-based, he really gave some evidence to that. And so, and I also had some public health people who kind of validated what he was saying from a purely public health point of view. So all of that was really great. And people left saying, wow, amazing evening. And, got the emails coming back, the next few days that followed saying, that was really eye-opening. Thank you so much for organizing that. And then, I gave it a week or so before I really started chasing them. I say, so what are we going to do now? Are we going to form this collective, which was part of my original provocation in the blog that I mentioned earlier? Nothing happened. So now we're into sort of holiday period. And then we go into 2023. Nothing happened. I mean, it was just, pushing uphill constantly. And then one person decided that they were actually really interested in that. And that was the director of social impact for Legal & General, which is actually the largest pension fund in this country and one of the biggest investors in places and properties. And he took a real interest in this. And that was 2023. And then by the end of 2023, we decided we were going to do this report, which then began, I think, Jamaica, if I'm correct, was January 2024. So we're a year on. But that's the backdrop to this. And the key was to not just build an evidence base around how does housing affect health, because we know that it does, but we actually consolidated a lot of that research. And actually, Mickey will talk a little bit about that in a few minutes. I realize I'm probably going on too long, but I think it was actually the first comprehensive piece of research that interrogated and convened leaders in the industry, because during the process of doing the research, we did have another one of these roundtables, and we did, as Jordan will tell you, speak to leaders and other people in the industry. So I think it is the first one where we really pulled together those kinds of insights, those kinds of practices, those kinds of resistance, and those kinds of embracing about what we are talking about. And again, we'll talk about that when we come to the recommendations. But I just wanted, before I hand over to Mickey, I just wanted to give you that backdrop that it did have a genesis. It was hard work, and we're still finding that this is not an easy process. I think we have crossed a couple hurdles, not just us, but, time moves on, events happen. I mean, as we all know, we're now to January 2025. We're living in a state where the government has housing and health as its top priorities. We are at this inflection point. It's a really good time to talk about this. We now have an evidence base this report has contributed to. So all of that, I think, convincing the industry that they have a role to play in public health and health equity in particular. I think we're 80% there, but in terms of actually incentivizing the industry to work collectively and to actually change practice, we still have some way to go. So I think that's the big message that I wanted to share, and where this came from. And then I think I'll pass over to Mickey now. He can talk about what this research looked like, what the evidence base that was actually built looks like, and what the structure of the report actually looked like as well. Thanks. Over to you, Mickey.
Sure. Hi, I'm Mickey. For those of you who don't know me, I see some familiar faces around. I'm just going to run through the structure of the report quite quickly. What I'm not going to do is give you a lot of the figures, because I'm trying to do this without notes, and there's nothing worse than misquoting a number. And also, I think it's a bit unfair to give people numbers when they don't have the references to check I'm not making it up. So I would urge you to look at the report, which has a lot more detailed figures around some of these things. I think as I'll come to, and as Claire's already sort of mentioned, the fact that homes and neighbourhoods have a huge impact on health is not only not surprising to people in this room, it wouldn't be surprising to a Victorian industrialist 150 years ago that homes and neighbourhoods have a huge impact on health. There are medieval peasants who wouldn't be surprised to be told that a damp and cold home is bad for your health. So while we now have all sorts of research to back that up, that it's also not exactly news. So our headline is, and as I say, it's unsurprising, that a warm, dry, well-ventilated, affordable, secure home is necessary for health. And yet, for at least 50 years, and there's a good argument for quite a lot longer than that, we simply haven't built enough homes like that. We haven't built enough neighbourhoods like that. And that's why we have a housing crisis and a health crisis that are very intertwined. At the sharpest end, in the last few years, we've seen, the deaths of 72 people in Grenfell Tower due to inadequate safety regulations, and perhaps even more importantly, inadequate enforcement of safety regulations. And we've seen the death of Al Abishak, which was ruled to be as a result of the damp in his home. As always, when we have these crises, perhaps unsurprisingly, the brunt is borne by people who are already facing disadvantage in terms of socioeconomic disadvantage and in terms of being from minority ethnic groups in both of those cases. So this is why we think it's very important that we desperately need to build more homes. But one thing that is also critical, and this is what every different interest group will say, is that we have to build the right homes. The reason for that is when you build a home, especially given the ongoing environmental concerns, we want those homes to be lasting 100 years or more. And therefore, we can't afford to build the wrong kind of homes, even though we know how urgent it is that we build homes in neighbourhoods now. The trick is how we come up with a way that we can embed health equity in the way we build homes and neighbourhoods that is not just another hurdle, but instead streamlines the process. by building in health equity from the start and building in community co-production from the start. What we don't want to do is simply be another group of people saying, well, this is another thing you need to consider before you build anything, which simply results in the problem we have now, which is not enough. And also the other thing that we try to address in this is why should industry care, which I will go into in more detail, but there are, we're never sorry to make the moral case about why, people deserve to have health supporting homes, but we can also make the economic case in terms of productivity for economy as a whole, and in terms of benefiting individual companies in providing homes that are more what the market wants, what consumers want. So I'll just quickly run through our structure. To break it down a bit, we broke it down into housing and places, and we broke down housing into quality, supply, and affordability. Obviously, those things are tightly connected. I would suggest that our root problem is supply. That has knock-on effects on quality and affordability. A lack of supply obviously has driven up costs. It's also driven down quality for multiple reasons. One is that if we don't build enough new homes up, we have the oldest housing stock in Europe. And perhaps unsurprisingly, then a lot of that is of poor quality. But also, if there's very limited supply, people have very little choice over their homes. They often have less of a say in disagreements with landlords about who, they have less option to turn down unacceptable homes. So on quality, we talk about damp and cold, we talk about overheating, we talk about safety, and as I've said before, safety particularly being effectively regulated and that regulation and enforcement being funded. We also talk about supply, the health issues related to supply. We particularly talk about at the sharpest end, homelessness and rough sleeping. The health effects of rough sleeping are absolutely awful, but the health effects also of children in temporary accommodation is by now well established. The health effects of overcrowding. So we saw that particularly families living in overcrowded homes saw more spread of infectious disease during COVID, for example. And on supply, we also touch on a few things that I can talk about more that are perhaps slightly red herrings. Do still find people who say, no, actually, we definitely do have enough homes. That isn't true. And we find people who say, the real problem is that we have a lot of empty, unused homes, which I'm afraid is also not true. We do have some empty homes that are derelict, and they're, derelict homes cause damage to neighbourhoods. And there are a lot of good work going on to remedy derelict homes, bring them back onto the market. But what's not true is that we have a large supply of empty homes that we could just solve this problem with. We have the fewest empty homes of any country in the OECD. And a functioning housing market would have a lot more empty homes. You need those for people to move into. We'll talk about affordability. So the affordability of your home also has great knock-on effects on your health. We hear a lot about fuel poverty nowadays, having to choose between heating or eating. So if your home is of poor quality and also very expensive, then you're spending a lot of money on rent, you're spending a lot of money on fuel bills, reducing the money you have available to spend on food and other important things to support health. And affordability in general is getting worse in this country, where particularly in terms of, the way we classify affordability is quite complicated because governments like to come up with new, relatively affordable things. The majority of different forms of affordable housing are not affordable to people on the lowest incomes. The most truly affordable classification is social housing, and homes at social rents have been dropping even as a proportion of affordable homes. Very quickly on places, I know I'm going at great speed, but please read the report. It's just to give you some context. So on places, we talk about amenities and services, we talk about communities, and we talk about the environment. So amenities and services are about, education, healthcare, all those things. So we like to sort of center the idea of this a local plan early on, that local government ensures that they are planning for the necessary infrastructure to support growing communities. When we talk about communities also, we talk a lot about co-production. Now, where I would draw attention is that we talk about having co-production from the start. So, proactively engaging with communities to ensure that development meets the need of those communities. I was reading someone this morning who commented that Britain's current planning system prioritizes the objections of anyone who might be disadvantaged by any development, but never gives a voice to people who might benefit, people in temporary accommodation, homeless people, because they aren't yet identified. So there is good evidence, particularly from the US, but I think it applies here as well, that when you proactively seek out wider community engagement from the start, as opposed to inviting objections later on, you hear from groups who are less rich, less white, less likely to own a home already, and more likely to be pro-development generally, because the public recognizes that we need more homes, but our current system tends to prioritize people who want to object, and those people tend to be those who are already relatively comfortable. So we're not saying less community engagement, we're saying more, but we're saying trying to make it truly representative of the community. And I won't talk too much about environment, if only because there's an enormous amount of other work, lots and lots of think tanks and charities and regulation and things going on around the environment. From a health equity perspective, we're trying to specifically identify sort of win-wins, so improving energy efficiency, because as we've said, that improves people's financial situation, their health situation, and is good for the environment. So we're trying to pick out those win-wins. And I'll also say we generally give support to the idea of urban densification, which the government has already suggested they're interested in. Urban living having a significant lower carbon footprint than rurality or suburban. And then there's a whole section on the planning system, which I could go on about 4 hours, but I won't, if only to reiterate that the recommendations we've made around the planning system are to ensure that we have central targets that are so that we really do provide the homes that we need, but with an empowered local government to look into how they achieve those targets so that it meets the needs of the local community, that it's co-produced locally, but that they are also held to a standard of producing the homes that we need. And one thing that we should see that as essential infrastructure funding, including the funding of local housing teams and local planning teams, that we're not going to get the homes we need unless local planners are properly funded and empowered to negotiate with developers from a position of strength, and connected up with our public health teams so that they have the best possible information about the needs of the local community, both in terms of health and more broadly what we call the social determinants of health, or the building blocks of health, if you prefer. That was a lot, and I didn't even get into the need for more disability-friendly homes and homes that are adapted to the needs of older people, which is, of course, extremely important. So many other things I could talk about, but I want other people to talk. I will hand over to Jordan right now, who's going to talk a little bit about some of the interviews and connections we made in producing this report. Thank you.
Hello, thanks, Nicky. Hopefully my internet is okay. It's a bit bumpy for a second there. Yes, so stakeholder engagement. So the Quality of Life Foundation led on the stakeholder engagement for this research, and we carried out both an online survey and a extensive set of interviews with key stakeholders to understand the barriers and opportunities to promoting health equity in the development and stewardship process. Additionally, this sort of engagement aims to basically gauge the built environment industry's knowledge of and knowledge capacity to address health equity, and to identify any recurring themes that could inform the report. So the stakeholder groups were chosen to reflect a variety of organisations, industries, genders and purposes. These organisations either directly build, facilitate building, regulate building, or work in social impact and health. And it brought out some really interesting findings, like just being able to talk to people who, in some respects, were very high up in their organisations and leading practices which sit at various different spectrums of the industry. So one of the key findings we had was around knowledge. So one of the primary findings from the stakeholder interviews was that there is a general lack of knowledge in the residential development industry about health equity and how it can be addressed. So interestingly, 68% of those surveyed acknowledged that there were knowledge gaps in their organisation on the topic of health equity, but only 81% said that health equity informs their organisation's decision making. So there's discrepancy between the acknowledgement that health equity is important, but actually the use of it in their own practice. But on the other side, there was a much clearer understanding of health equity amongst survey respondents who were from other industries such as the NHS, design practices, and social change charities. So this suggests that there is somewhat of a gap between the property industry and other organisations, and the potential for those to learn from each other to develop sort of more theoretical and practical understandings of health equity, and how it can be applied. So the other issue that came up quite frequently in the interviews was the idea of trust. So a lack of trust was highlighted by interviewees time and again as one of the key challenges for developers, investors, and operators to overcome. So building trust between the property industry, so those who develop and operate homes and communities, arguably reduces the risk of local oppositions or community exclusion. And overall, we argue encourages better outcomes for all. But again, developers, investors, and operators need to show a better understanding of local needs, and a desire to meaningfully address social and health inequity to do that. And as sort of building what Nikki was just saying, you know, meaningful community engagement and needs assessments can sort of help create simple place-based indicators on outcomes for residents and local people that can be followed through in development processes and sort of embodied and embedded within sort of stewardship plans. There were a variety of other sort of barriers that were identified. So for example, in terms of any regulatory and policy environment changes, it was argued that there was a consistent and clear lack of policies and standards around designing for health and well-being in new developments. Arguable, but I think it's something which needs to be developed, and I think there are changes now happening where health is being put more front and centre in the policy around housing. The slow pace of policy changes in terms of embedding health considerations in planning was argued to be detrimental to meaningful change or timely change. And the fragmented nature of the planning industry with siloed approaches between planning, health, and social services means collaboration is challenging. So Mickey made sort of a comment around sort of housing for disabled people, older people. There is a huge issue, as I'm sure a lot of you know, around, at the moment, about people not being able to leave hospital because their homes are not suitable to support them. And this is creating a huge health impact for multiple people, and the housing industry has just not been able to respond to that in time. Then there was also in terms of issues around industry perception and culture, in that the risk-averse nature of house building industry makes it very slow to adopt progressive ideas. There is the cultural and social perception that house builders prioritise profit over quality of design and placemaking, and this enforces that additional culture of mistrust and disconnection with communities. And as mentioned in the beginning, there's a general lack of awareness and knowledge gaps within the industry around health impacts of the built environment. And there's a resistance to change. You know, there is reluctance from developers to adopt new housing models and to design approaches that prioritize health and well-being. And then finally, there is an increasing challenge around capacity, where the underfunding and hollowing out of local authorities, planning departments, limits their ability to practically plan for health, and to work with developers on that. There is an underrepresentation of designs and health professionals in planning and development processes, but we're seeing now some interesting councils where health and planning roles are being combined together, and we can sort of share a link for some research on that. And one sort of issue which is less addressed in the report, but I think is equally important, is that the majority of housing stock is existing, not new development. So addressing health equity in the broader housing market is a much larger systemic challenge. I'm going to stop there so we have time to chat. Back to Claire.
Mickey and Jordan will add in. I'm just going to mention two of our recommendations that I guess I'm prioritizing them for what I want to say, because they're the most, in my thinking, practical, and they're the ones that sort of have an immediate instrument, as it were, to actually change practice and take some action. And those two, and I've been watching the comments coming through, so I've been sort of chomping at the bit to respond. There was somebody who mentioned health impact assessments. So they're the big elephant in the room here. And then the second one, which I haven't seen mentioned, but I haven't been studiously looking at these comments because I've been paying attention to what everybody's saying, is this, I'm going to use the term developers' contributions, because we know them as something called Section 106. I realize everybody here in this webinar is not a planner or particularly familiar with various planning terms, but there is something in planning law called developers' contributions, which have at present, this subject to change, manifest in something called Section 106 or something called the Community Infrastructure Levy, also known as SIL. I don't expect you to take notes on this, but it is worth knowing about, because these are significant pots of money that the landowner and the development of that land in a scheme will then put into a pot, so to speak, for the local authority to allocate for community use. Okay, so I'll talk really, really quickly about those two, because I'm really interested in what people think. So the health impact assessment is not mandated by law. First point, we can talk about that. And nor is it really addressed in the new national planning policy framework, which we can also talk a little bit about. And the point is they're extremely variable. So in fact, when I talk a little bit about the whole origin of this, and I don't want to keep banging on about the history of it, but it does provide context. One of the things that got me really motivated about asking the industry to collaborate around health was I actually live adjacent to a major regeneration scheme. And when I first saw the health impact assessment that was produced for it, and this was during the pandemic, so this is at a time when, I mean, to say there was heightened awareness about public health is putting it mildly. And when I saw this health impact assessment, I mean, I laughed because otherwise I would have cried, and I tend to be an optimist. And it really was a quite flawed, quite remote, quite indifferent sort of report that sort of said, you know, essentially this development will not really impact health. And I mean, I can go on in more detail, but it struck me about how it didn't engage the community at all. And B, it really used very little data. And so those are two things that I think could really be enhancing future health impact assessments. And what I would like to see, we can talk about this forever, what I'd like to see is I'd like to see the industry collaborate around a new standard, raise the bar on what health impact assessments do. Firstly, why we're all here, to address health equity. Secondly, to use better data, which is being generated all the time. And thirdly, and perhaps most importantly, to actually use the health impact assessment as a tool to bring the community in. And I mean, I don't know about you, but you know, I've been involved in so many community consultations, and everybody's got an axe to grind. You know, some people care about transport, some people care about education, some people care about trees. We all know that, but everybody cares about their health, and yet they're very rarely, if ever, consulted on this. And so I actually see, and this is part of our recommendations, is to develop an industry standard for health impact assessments that actually also bring the community in, so we actually have some local buy-in and local agency into any kind of change in their built environment. So that's the first thing. The second thing about the developers' contributions, so just three things to point out to all of you. Right now, this is all coming at us very, very fast. There's three things happening with developers' contributions, and this is all evidence. I won't go into all the names of people who've collected it, but there is evidence that a lot of local authorities are sitting on Section 106 payments that just haven't been allocated. Now, there's all kinds of reasons for that, but there is money there. Why isn't that benefiting the community? First point. Second point is there's an emerging trend of developers who will get planning permission for a regeneration scheme, and then will suddenly say, oh no, we can't pay into the Section 106 funds because otherwise the project won't become viable. So whether or not those commitments were around health or anything else, that's a trend. We haven't actually, I don't want to say that there's a whole database to actually measure that, but we see it anecdotally. And then the third thing is that there's actually an opportunity here for community groups, local people, to get involved with the negotiation around the Section 106 payments around their local health. And this comes back to the health impact assessment. The two can actually work hand in glove. And these are things we'd like to see. And we'd like to see the industry take a lead on this.
Well, thanks for covering those recommendations, Claire. Marcus, you mentioned that you work in a charity on the front line and you had a question about broadband. Go ahead.
Yeah, hopefully quite short. We can see that digital exclusion has a major effect on health for all the reasons you can imagine. It's a very long list. There's obviously existing areas which have very poor broadband provision or digital provision, but more concerningly is new developments. There's lots around Cambridge, and either there's nothing put in, nothing specified, or the developers promise it will come after the development and years later on that still be delivered. In some cases, developers even go bankrupt or walk away from their obligations. So why should there not be minimum standards for digital inclusion and broadband supply mandated and managed by the local authorities as a condition of awarding approval to the builds?
Mickey, Jordan, yeah.
I'm happy to. So in more general way, I think this is related to one thing that we do cover a lot in the report, is as has just come up in the chat as well. Sorry, it's in the corner of my eye, but I think it speaks to a more general point, which is that the planning department, who are the people who negotiate on Section 106, for example. So Section 106 is negotiated for specific projects, and the infrastructure levy is more of a general pot that could be used for example, broadband. Is that we've lost a huge number of our planning officers in the last 10 years or so. Government has announced a plan to get more, but not to the level that we had before. So, when it comes to broadband or to any other sort of necessary infrastructure, we need to be empowered. We need teams that are funded and empowered to be able to negotiate and get the maximum they can from developers. And that requires funded planning departments, and it also requires, I think, support for community engagement earlier on, so that once you have a local plan and planners know what the local community wants from their developments, we're not going back again and again, and we're not working on the basis of objections. We have a planned, we have a funded and informed planning department that is able to demand these things and get them, whereas at the moment they're struggling to sort of negotiate.
Thanks, Vicky.
It's a bit of a generalization of what you said.
Thanks, Marcus, as well. Can I bring in Carl? You mentioned a George Monbiot article, which was as provocative as they usually are, and HIA, and Claire covered HIA, but is there anything else you want to bring up from
that? Thanks. I guess my question is, and I agree with what Claire was saying about HIA, is in the face of the government challenge of build, how do we actually build in something like HIA in a way that will address government and industry fears that HIA or health equity assessment are just building in delays into the system and goes against build. And I think that to me is the nub of some of the challenge there. And I completely agree. I think we need to get HIA mandated flexibly into the NPPF. Thanks a lot.
Anything to come back on that?
So I know I just spoke, but I would say absolutely. And I think, one of the ways we can make it less of a hurdle is, I think, thinking intelligently about scale and having a proper local plan where we assess the health equity impact, the health impact and the health equity impact of an entire local plan, which would facilitate smaller developments that already fit into this local plan, would get through relatively quickly, which might also break some of the monopoly of the bigger house builders, make it easier for self-builders, make it easier for small and medium enterprises, community groups because they know up ahead, this is, if we fit into this local plan, which has been impact assessed, then we will get approval and then we can build. For the bigger developments, I suspect we will still need to have, bespoke impact assessments on the basis of their building whole neighbourhoods. But I think, if we put our impact assessment at the level of the local plan, which will again require proper funding of the planners, then it will open things up for more diversity within the building sector, because they'll know in advance what boxes to tick.
There are a lot of comments, Carl, about HIAs, and people have posted, thanks Fiona for the one from Glasgow, and also Kate from Oxfordshire. Clearly an issue of interest to many people. Kate, would you like to come in?
Hi, yes, hi, I'm Kate Schoen. I'm the Managing Director of Taurus Foundation. We're part of Taurus Group, a social housing provider in the northwest of England, and we own and manage 41,000 properties. Can I ask, were social housing providers considered as part of the research, or did this really focus in on the private sector? Because I think everything that you've said is, absolutely fantastic. One of my key concerns within the social housing sector in particular, is where we are seeing more social housing providers having to pull back on their development programs because of the financial risk that it carries, particularly with so many contractors going out of business. We've seen many organisations where they've been developing in the past, they've had a regulatory downgrade, in terms of their viability, which lessens the attractiveness for funders to want to back home building. So I just wondered whether any of that was considered in the round, because there's more fragility in the sector, particularly around house building, than there's ever been before.
Alan, do you want me to just make a quick response? I'm really glad you brought that up. So we did have, as I mentioned, these roundtables, industry roundtables. L&Q are participants in this. HACT, are you familiar with HACT? Those are the two that stand out. But yes, they were. And I think Jordan might comment on some of the social housing providers that he engaged with. So yes, they were. I just want to pick up on something you said about financial viability, but this time on the social housing provider, because when I made my sort of spiel earlier about what's happening with the Section 106, I mentioned three things. I'm not sure I made it clear what the third thing was. I mentioned the first thing about funds that are going unspent, but I may have not made it clear what another one was, which is that there's been, now again, I would really love to hear from you or anybody else in the social housing sector on this call. I have seen that people saying in certain areas that there are Section 106 housing that has been not only funded, but provided, built, that has not been taken on by social housing providers for exactly the reasons you say. And I'm really interested to know if that's true, to what extent it is happening, because if it is, that is something else that we really do need to get to grips with. And again, I think back to some of the other questions too about health impact assessments, the industry has to take a lead on this. I think there's some overriding conclusion to this whole piece of research, is that we can't do this without the industry taking a lead. And this is the big conundrum. How do we actually make, as what Mickey said earlier, this look good for the industry? And, we think health impact assessments are an opportunity. Yes, they're a challenge, but they're an opportunity. There's an opportunity to pull in community groups, all the things we talked about, to work with the local health providers, to work with integrated care boards. So we have to make that case. Personally, and Jordan might want to comment on this because I think he spoke more to social housing providers, I think people like you have a massive role here. And I'd like to see that, spelled out, and I'd like to see that much more integrated into these impact assessments and the use of the Section 106.
Anything you'd like to add, Jordan? Is that?
Yeah, just that we spoke to HACT, but also the Housing Quality Network for this research, which gave us sort of really useful insight into the particular challenges that health equity raises within that sort of social housing context, and spoke a lot about the sort of accessibility of homes, but also one topic that came up frequently, but especially in social housing, was the location of homes, and the fact that the location of social housing and the infrastructure that surrounds it and facilitates it is equally as important as the homes themselves. I would argue that, yes, I think a greater impact on social housing and health equity, a greater focus on the relationship between health equity and social housing would be a great next step for this. And it is stuff that we're looking at within the Quality of Life Foundation as well. Because I think a lot of issues were raised which have a completely different sort of set of requirements and responses, but looking at social housing context rather than sort of private rented development. So yeah, thank you for the question.
Alan, can I just say one other thing about this? Because it's, you know, one of the things that came out from these roundtables that I think was so interesting was, and I'm picking up on someone's comment on the chat, which said infrastructure first. So whoever did that, thank you, because that's like a mantra of mine. Because we found that, you know, first of all, the most affordable housing in this country is actually funded through Section 106. And secondly, GP surgeries are increasingly funded through Section 106. And too often we see a housing development that, you know, adds several thousand new residents to a community. And, you know, what's an already stretched primary care facility is stretched even further and often with, you know, serious health consequences, not to mention health equity impacts. So that message does not seem to have gotten across. And in fact, it was incredibly palatable at the roundtable. And again, it goes back to some of the things I said earlier and what Jordan also picked up on, this lack of knowledge. And there were people who literally said, oh, yeah, we pay for health. We care about health equity. We fund a GP surgery. And, you know, that's a good thing. No one's going to, you know, sit around and say, don't do that. But it's, you know, to use a bad metaphor, it's kind of the cart before the horse. And, you know, this goes back to the idea of a new kind of a rethought, a reapplied, a redesigned health impact assessment that has an infrastructure first policy, and infrastructure health equity being a key component of infrastructure. So we still do have a long way to go. But, you know, when you look at the fact that you've got housing that's done through Section 106 and GP surgeries that still don't provide the necessary social and health infrastructure, we have a challenge ahead of us. Do I sound doom and gloom? I don't really want to sound that way. I'm trying to get people excited for trying to drive this forward.
Thank you, Claire. Mickey, if you don't mind, I want to bring in the last 2 points and
sure.
Apologies if maybe you could pick them up. I'll come to you in a minute, Bob, but first of all, Claire, Gemma Hyde from Town Country Planning Association. Gemma, you made a lot of interesting comments in the chat. One that mentioned the planning system is not the prime source of the housing crisis. Would you like to expand on that?
Yeah, that's a small question, isn't it? This is a really fast moving thing with obviously talking and so much going on in the chat, which is really fascinating. I think it's just we're a little bit stuck in a doom loop on the planning system currently, and a lot of that is coming from government with the focus on growth and the planning system being the problem. I think we just have to remember that you can't live in a planning consent. I think that was the point I wanted to make. So we can consent lots and lots of things, but there's that's a part of the equation in terms of how we actually create homes for people to live in, and actually then that those homes are you know, health promoting and health creating and safeguard people's health. So it was just that point really. And if anyone's particularly interested in sort of planning stuff, then we do a lot at the Town and Country Planning Association, sort of thinking about some of these things as well. So please do check out our website. But I think that was the sort of what I wanted to raise really. And if I may, on health impact assessment, because I now have the floor, it's absolutely possible under what we already have for local authorities to create health impact assessment requirements. The problem I think that I see is that the way to do that is not really clear. It's not set out. There isn't a national framework to do that. So unlike somewhere like Wales, which has you know, a unit to support that work and create it nationally and have a national standard, we don't have that in England, and that is a problem. So it's possible to do, but then you get huge variation, huge differences in trigger points for what HIA is for, and therefore you get a very patchy and very negligible impact, I think, from using them. So that's sort of where I come on that.
Thanks, Gemma. Claire.
So thank you for bringing up Wales. And I noticed on the chat, a couple people have said, are there exemplars and are there templates? So if anybody's interested, I'll figure it out. But I did interview the people at Wells, and I've done a piece on that. So I'm very happy to share that with people if you want to get in touch with me somehow after. And yes, it's much more than just a report. They've literally integrated their practices, and it's at the end of the day, it's about people who like to talk to each other and want to face a common challenging problem and deal with it. But yes, they're doing some great work, and very happy to share what I've put together around that.
And yes, do follow up links after the network webinar. Bob, and then I'll come to you first, Mickey, if you want to pick up those other points I didn't give you time for. But Bob, please go ahead with your question.
I think Claire's already picked up on it. I was very impressed with the Welsh Government's health impact assessment and toolkit, and I just wondered whether that had influenced your recommendations.
Go ahead, Mickey.
Short answer is yes. Yes.
Okay. Mickey, go ahead.
I was just going to come back on a couple of things a little when we talk about housing associations, just to flag up the one thing we mentioned is that there's a problem at the moment with affordable homes being built under Section 106 that aren't the affordable homes that housing associations, who are the eventual purchasers of those homes, actually want, which means those are sat unbought. It means the project can't continue because the developer hasn't successfully sold the affordable housing they said they were going to provide. And that seems like an easy win in the sense that that is a communication failure rather than a failure of funding or anything more complex. It's not more expensive. It's simply the fact that if housing associations aren't involved early on and expressing what their perception is of the needs of the local area and what affordable homes they actually want to buy and then provide to locals, then you just end up with the wrong homes. So I think that's very important. And the other thing, just one thing in the chat mentioning some people who weren't yet involved. Just to be clear, I don't consider this report, or indeed any report the IHE has ever produced, to be the final word on anything or even close. So the idea is that this is the beginning of ongoing work. So we absolutely are working with local authorities on this, and we'll continue to do so. I think that's about all I wanted to say. I think on the planning system, I agree. It's not the be all and end all, although I suspect it is one of the bigger opportunities, but it's not the only lever we have.
Thanks, Mickey. I think we're down to the. I don't think we've got any more questions coming, but there was a point, Claire. Someone, Chris was asking about making your interview work available on the network. Would that be possible? Hopefully, I'm not putting you on the spot. Yeah, great. Okay. If we don't have any more questions, is there any final point, Jordan or Claire, that you would like to make?
Oh, what about me?
Just get involved. This is really interesting stuff. And, we may complain about everything that's happening in housing and health, but this is the first time people in top of government are talking about this. So there's a real opportunity to start making some of this stuff happen. And, we can talk about it at the top level, but equally we can do individual things in our own communities and set examples. And actually I promise this is my final point. One of the other recommendations is we have literally put a call out to industry leaders to work with us to develop some of the things we're talking about, new ways of doing health impact assessments, new ways of using developer contributions in the framework, the policy labs, if I can say it that way, of Marmot cities. Again, we could probably have another discussion about this, but that's what we have called on the industry to join us in trying out. So, watch this space, but really welcome people's feedback on this, because it really is, a very organic but very fast-moving area. Thanks.
Thanks very much, Claire. We have 1 minute left. Jeff, I couldn't actually see that your hand was raised, but yeah, it's been brought to my attention. You've got a question.
Yeah. Hi guys, apologies for appearing late. BRE's research on the NHS spend a year on poor housing costing the NHS 1.4 billion a year raises the issue that in improving poor homes, and BRE's got lots of data on it, there is no way currently within the Treasury rules for the NHS to pay forward for improving the range of old homes that need to be improved, and say there's 200,000 a year. at this point in time. So in all this work, it's very important to think about, the information from the HHSRS on poor homes, but then link it to the fact that this is causing illness in the elderly population, which will increase by another sort of 1.4 million a year, whatever. So that we need to think politically about how the money is moved around. There is an obvious benefit from the government paying to do up those homes to the NHS. And it's a quite straightforward balance sheet, and I'm sure HEN can develop it.
Brilliant. Final comment then, Mickey, Claire, Jordan.
Yeah, I think just a small plug for the Homes, Places and Health Equity Group and the Health Equity Network. Jamaica and I are starting to work on building that group up, and where we can have more of these conversations over the next sort of few months and so on. So I hope that becomes a place for all these questions to kind of be hashed out and talked about a bit more. So yeah.
Thanks, Jordan. Yes, there is a way of continuing this discussion. Thank you very much for mentioning that. Mickey, Claire, any final words?
Yeah, can I just quickly mention, just in response to someone in the chat who said Marmot cities and we're leaving behind rural areas, Marmot places. We have Marmot cities, we have Marmot towns, we have Marmot regions, we have Marmot coastal regions, we have rural and urban. So it is broader than that. And the other thing I just wanted to say that I think Jeff absolutely summed up, frankly, what goes beyond even the housing discussion into what we generally talk about in terms of social determinants of health. We can't have a system where we're willing to pay for people in extremis when they're most sick, but we're not willing to pay to stop them getting sick. It's becoming increasingly clear how unsustainable that is. And that applies to housing and it applies to all the social determinants of health. I think Jeff really summed it up brilliantly.
Thank you. Thank you, Mickey. And I will close with a plug for the Rural Health Equity sub-network on this network, which is one of the most active that we've got. Veronica Ratic is an excellent convener of that group. Please do join Veronica. Thank you very much to Mickey, to Claire, to Jordan. Excellent presentations. Thank you very much to everybody for the comments and for the questions. Do join us again in a month's time when we'll have a webinar, which is going to be from Sport England, I think, on physical activity. Thank you very much. Have a good rest of the day.
Thank you.
Thank you. Bye.
Thank you.